So in February of 2021, someone paid more than $200,000 for a digital clip of a LeBron James dunking a basketball. Not the copyright, not exclusive access, not even the video itself. Millions of people who could watch the same clip online for free. So why would somebody spend that much money? Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On viral healthcare, we look at the ideas spreading across healthcare and what it takes to implement them wisely and sustainably. So let me go back for a second. What is this thing, this NFT or non-fungible token? That's what somebody bought when they got LeBron James dunking a basketball that anybody else could watch on YouTube. It's amazing. NFTs were this amazing discovery that they could say some person has a signature, has a something like blockchain that they couldn't actually take away that would prove that it's owned by them. It's amazing. It could be owned by 100 different people, but they could prove that this one was owned by them, and that ownership created potential value. It made it feel like you were getting something rare, something that was unique, something that was exclusive, and they exploded. It was amazing to watch these things happening. Celebrities used to sell off parts of their brand. Some brands got involved with it. Taco Bell sold NFTs for, go figure, millions of dollars. Even hospitals and academics, they got involved with figuring out how they could claim what medical records or some other things were unique, were owned by them, were possessed by a unique sort of signature or a cryptography that made sure that it was yours. That was the non-fungible token of 2021 and on. Everyone wanted in. Companies were creating divisions for NFTs. And then eventually, trading volume fell by almost 95%. If you just look at the art version of this, and you can kind of understand why people want pieces of art that make sure that they're unique, that they're traceable to be authentic pieces of art. The trading volume crashed in 2021 when it was at 2.9 billion, and in 2025 it had dropped 93% to 23.8 million. That's right, 2.9 billion to 23.8 million. It was amazing. The excitement disappeared just about as quickly as it arrived. So what's happening? I mean, I'm not really here to talk about NFTs or non-fungible tokens, but it's about something that's really common. And this just is a really great story of what happens to a lot of really smart people. When intelligent people are surrounded by all these signals pointing to one direction, that not participating begins to feel like the greater risk. My kids told me this one FOMO, I'm sure you've heard about it, fear of missing out. And that's what this is. It's a version of, if I wait, if I hold back, I'm going to miss out on the wave. I saw this with stocks. You see this all the time with stocks. By the time NVIDIA had reached, millions of dollars of value per person, it was too late. But you had this fear that you were going to be missing out, and so people jumped in at the same time. It turns out we see this all the time in healthcare, and we've talked about several of these FOMO examples before. And every few years, something else just comes up new that people feel like it's going to change everything. It's going to transform. It's going to really make a whole new, different, disruptive healthcare. Sometimes it does, but most of the time it really doesn't. Let's just tick off a handful of examples that we've talked about or that you might have heard about yourself. So right after the Affordable Care Act that President Obama signed, people thought population health platforms were going to be the rage. I mean, if we could just track people, we could actually make a difference. Wrong. Retail clinics. And we've talked about how retail clinics were kind of exploding, and then they've scaled back dramatically. In my area, in quality improvement, everybody was talking about lean or Lean Six Sigma, and very few do it, or at least do it to the level as before. Blockchain, that was talked about. Many conferences had that, many presentations, many articles, lots of discovery about how blockchain could make a difference. And We don't talk about it too much. Early AI, boy, everybody was talking about AI. And I remember going to conferences and seeing this use case and that use case. Now we're starting to see these things pop up for 3 or 4 years, nothing. Precision medicine, we talked about this last week, where people just thought that they could actually give exactly what each person needs. And while there's some truth to that and some specific examples where it makes a difference, it's underwhelming for now. Maybe 5, 10, 20 years from now, it'll be more dramatic, but right now it's underwhelming. How about digital therapeutics? I mean, the list goes on and on. We've talked about them. One of the ones that I hear about all the time are liquid biopsies or whole body MRI scans. These are these like Ponce de Leon things that I know how to make you live forever, when the underlying evidence so far isn't there. If anything, it potentially causes complications more than anything else. But they're not really the same kind of technologies, same problems, but they follow remarkably similar adoption curves. And that's what we've talked about with all of this, is how human beings, how people adopt and make decisions about these new activities. So if you're inside an organization, the question slowly changes. I mean, you're trained as an executive to ask these important questions like, is this right for us? But then you start asking, why is everyone else doing it? And if everyone else is doing it, why aren't we doing it? And that's a completely different question from problem solution to, wow, we better not miss out on this kind of stuff. So why does it happen? And this goes back to some of the things that I learned very early on in my career, that human beings are social animals, that we adopt new ideas, new innovations by looking around. Most of us don't kind of discover them on our own. We discover them because somebody has shown it to us, or we've heard about it, or we've seen an example of it. So this social nature is really important. And the reason we do that, it's really powerful, is that we're just overloaded with information with high uncertainty. So we look around to see somebody else to decrease our uncertainty. I mean, part of the reason I even consider wine critics is because there's thousands and thousands of bottles of wine out there, and I can't taste them all to know. And if I'm going to spend any kind of significant money, I want to have more certainty. So we do this in many phases of our life. We look around, we try to find out, can somebody else help us with our uncertainty, decrease our risk? So we ask these questions. Who else is adopting this? And I use this in quality improvement to sort of find early adopters, these opinion leaders. What are respected organizations doing? What are the conferences talking about? What are the consultants recommending? And sometimes all of these things align. And none of it really is irrational, but it's just about trying to reduce uncertainty and the risk. And we all want to avoid the risk of failure, probably, and embarrassment most of all. But it always has limitations. Everything has their limits. And this is where healthcare becomes different, because just because it worked in that organization doesn't mean it'll work in our organization. So this is a good example that I think we've talked about before, is Virginia Mason Medical Center in the Seattle area. They wholeheartedly went into this concept of the Toyota production system. We now call that lean. And they succeeded. Lots of evidence, lots of examples of how they were doing. In fact, they succeeded so well, they created a university to help other people learn from their example of how they did it. But they succeeded because most of the conditions that were necessary for success, people never saw. Most of it was leadership, commitment. I mean, they took out executives every year for 10 years to Japan to study in person the Toyota production system. They had a culture that was built around it. The language was built around it, from frontline, middle management, senior executives, all the way to the C-suite. Everybody talked in that language and had those expectations. They applied resources. They were in a position to be able to invest substantial resources towards those kinds of activities. And they made it a priority. They made it a priority by putting time towards it. And then they had something that some people have, probably not unique to Virginia Mason, but they had operational discipline. So they were able to stick all along the way. How would we do this using the Toyota production system? Those conditions don't automatically transfer to another organization. Some got it, but it's not the common organization that was successful in lean. Maybe 4 or 5 across the country that really did a great job of it to the level of Virginia Mason. That doesn't mean TPS or lean was bad for others. It just meant it was hard to replicate with it. So the problem is, the hidden mistake with all of this is healthcare often tries to copy outcomes without copying the conditions. That's why a lot of initiatives truly disappoint, not because the idea was wrong, but because the environment wasn't prepared, because the problem didn't manifest the same way in every organization, and probably because our organization wasn't really ready for that kind of a change to happen. So here's the thing. Most failed adoptions are not the result of flawed strategy and theory. They are the result of incomplete translation. Yeah, it's weird. Translation. Incomplete translation is the problem. And that translation is experientially and systematically driven. We've talked about that on the podcast many times, about developing a system to try to make sure we translate it effectively. So importantly, what people need to do is slow the conversation down. Instead of asking, should we be doing this? Is this for us? It's, what problem are we solving? Going back to the basics. And then we've talked about before, what will we stop doing? Because they're opportunity cost. And even if you think you're not going to stop doing something, you're going to pay less attention. You just don't have that much bandwidth, that much capability, that much organizational muscle memory to be able to tackle that many initiatives. And so when you start something of a significant imports, even especially if it's enterprise wide, you're going to slow down or stop or minimize some of these other things. So what will we stop doing? What conditions make this work elsewhere? Do we really understand what's going on with it? Do we have those same conditions? And if we don't, can we realistically create them here in our organization? So this example of the non-fungible token, the FOMO, the idea that you could watch it on YouTube and yet you pay $200,000 for some kind of signature that says it's authentically yours. Think about all the things we've talked about: consensus decision-making, groupthink, skipping or bypassing useful steps like the pre-mortem, wholesale implementation rather than iterative deployment. My personal example, the UP campaign, how we had a lot of sizzle and very little stake. They're all asking the same question. They're all addressing the same issue. How do we make thoughtful decisions while everyone around us is seemingly moving so quickly? And like I've discussed before, moving quickly is often an illusion, because the things that have attention are the things with momentum. The dull and sort of underwater, those hidden kind of things, those actually move much more quickly, but it seems like everybody's doing it when you see it all around you and you hear all these stories. So here's some important leadership lessons. Innovation, adoption of innovation, new ideas, new platforms. It's not a race. It's rarely a race. I'll talk about this more in the future, but healthcare is not like an IPO. It's not like, if we're not the first ones in, this first mover advantage, we're not going to be there. There are a couple of occasions where delaying is a problem, and we'll talk about that as well. But most of the time, it's not a race. It's a resource allocation decision. Every yes that you say about a new idea, new platform, new initiative requires time, requires money, requires attention, requires leadership, requires staff, requires operational capacity. I could go on. And those resources are finite. You only have so much. So you have to make wise decisions and really understand the opportunity costs. So the NFT story isn't interesting because NFTs rose and fell. We're going to have many more of those over the next 10 to 15 years. It's really interesting because it reminds us how easily intelligent people, super intelligent people, can mistake momentum for evidence. Healthcare will always have another trend, another platform, another promise to transform care. There's that word again. The challenge isn't deciding whether innovation matters. It's deciding whether this innovation fits our organization at this time and not just someone else's. So the next time someone seems that they're moving in the same direction, don't ask, are we falling behind? Instead, ask, if no one else were talking about this today, would we still believe it's the right investment for our patients, our staff, and our organization? If you enjoyed this story, come watch me every Tuesday where we discuss these kinds of topics about healthcare and decision making and implementation and how to get ahead, how to do it wisely and sustainably. And if you're working with somebody who has similar kinds of ideas, share with them what you're learning here or go to your favorite podcast platform and learn from them. Until we see you the next time, I'm Bruce Spurlock, and I'm looking forward to talking to you more about viral healthcare.